Can you see the slides?
Yes.
Okay, so they asked me to briefly talk about the trick valve system and also to present a clinical case. I'll go briefly through the system itself and the indications, and then also a brief case just that shows how does it goes in real life. Just very quickly, we all know that surgery is not the perfect solution for patients with tricuspid problems, much more if the patient has only a tricuspid problem and not other valvular regurgitations or valvulopathies. So in this context, surgery hasn't showed to improve really survival, as you can see here. So we need something else to offer to the patients. And in this context, we've got some current interventions that previously have focused on edge-to-edge repair. Also, we're still developing some systems that allow us to replace the valve orthotopically. But the success of these therapies usually relies on very specific anatomies, and also they rely on a very specific and quite demanding periprocedural imaging guidance. In this context, we've got the trick valve system, which has got some advantages. As you can see there, it's a heterotopic bicaval stenting transcatheter strategy, okay? It's based on a streamlined fluoroscopical workflow that we're very familiar and used to, just like, or very similar to the TAVI procedures. And also the procedural planning is quite easy. It mainly relies on the CT screening, okay? In comparison to previous non-orthotopic devices, it also has some advantages, as you can see there, because previous devices had some difficulty on sizing, anchoring, the necessity of prestenting, and also a risk of embolization. The trick valve system has got two independent and separate valves, specifically designed for the IVC and the SVC. You can see the images. On the left side, the SVC valve for the superior vena cava. It has got a belly in the middle part of the valve that allows for the retention and also prevents embolizing distally. This belly should be at least half of the belly above the right pulmonary artery, just to prevent the valve going downwards or caudally. And also on the right side, you can see the IVC valve, which has got a short skirt here, just to prevent any leakage and just to avoid closing or stopping the flow from the suprahepatic veins. And then the distal part is much more bigger, just to allow for stabilization in the IVC. The valve comes pre-mounted, which is very useful and very quick, and also facilitates the procedure itself. Which are the candidates to offer this system? We've got patients with obviously TR, which are not suitable for repair. They cannot be treated with edge-to-edge therapies. And we need to offer them a CT screening, a right heart cath, and also an echo screening. The criteria are quite easy. We just need some significant V waves above 15 just to allow the valve to work properly and all the leaflets to open and close properly, and also avoid severe pulmonary hypertension to avoid early dysfunction of the valve. In the echo screening, we just try to avoid patients with severely reduced LV or RV function. And also we should try to avoid intracardiac shunts because they could increase right to left shunting after the procedure. If there's a shunt, we can close it before performing the trick valve implant. For the CT screening, you can send all the images to the company. They can analyze the distances for you. we just need some measures from the innominate vein to the RA, and also some dimensions. We've got three models of the SVC from 25 to 33. This is the dimension of the valve itself, and we can cover ranges from 19 to 40 millimeters of diameter. In terms of the IVC, we also look for this minimum distance between the suprahepatic vein and the right atrium that should be above 5 millimeters. And also we've got some different sizes of the valve, which covers from 24 up to nearly 45 millimeters. Let's move on. We can. I would like to show you just a case. It's a particular case, not easy, but I think it shows you how we can use this valve in some different contexts. This was a 77-year-old female with chronic AF, also previous valvular heart disease, with 2 previous intervention and a mechanical mitral valve. She had currently severe TR, due to huge tricuspid annular dilatation. She was in very bad functional class on high doses on diuretics, and she also had some comorbidities which precluded a third redo for this patient. You've got here some images from the previous echo. You can see there's a huge gap here between the leaflets of the tricuspid valve, which recommended not to attempt an edge-to-edge procedure, and also obviously severe tricuspid regurgitation. Some more images of the previous echo. You can see them here. And we perform a CT screening. These are the dimensions of the SVC. It was a special case because you can see here, just like a very tortuosity of the SVC, a huge loop here. You can see also in the right image that made it difficult to to implant the SVC prosthesis, as you could see later. And also afterwards, after this loop, the SVC was really huge with a very big dimension, which made it necessary to implant the valve up here above the right pulmonary artery and not distally where the SVC was too big. If you can see the images of the IVC, you can see there was a minimum dimension or length between the atrium and the suprahepatic veins. You can see them here, but because the suprahepatic veins were quite large, we thought we could implant the valve and leave the skirt here without covering all the suprahepatic veins. Just moving on to the case, for a normal standard procedure, this is the material we need. Everything is quite usual in a cardiac cath lab. We started doing the procedure with transesophageal echo for the first 4 or 5 patients, but nowadays we do all the procedures just with transthoracic echo. Just we do all the SVC implant only relying on the fluoro, and for the SVC procedures, as you could see later, we just check the amount of the valve or the amount of the system that is inside the right atrium with transthoracic echo. We do the procedure on mild sedation. Invasive pulmonary, arterial pressure is not necessary. And you can see the procedure here. On the left, you can see, and also on the right, some angios, initial angios of the SVC. You can see the loop that we previously watched on the CT scan. And we also had a catheter, in this case, in the innominate vein, just to make sure where the innominate vein was, trying not to occlude that vein. This is the system. This is the SVC system. You can see it's pre-mounted. It navigates quite well. It has got a nose here, and you can go up to the place where you can start to release the valve. unsheath the valve, you usually leave a catheter through the contralateral femoral vein just to check where do you want to start the deployment. You start unsheathing and the valve starts expanding and becomes functional in place. This particular case, you can see how we can straighten the SVC as we deploy the system, and we do it slowly just to let the valve expand and stay in place. You can see the belly here is above the pulmonary artery, just to make sure that the valve stays in place. You can see the final release here. And also, it's important to retrieve the system carefully, just to make sure that the nose cone doesn't pull all the system backwards. So you can see here how the nose cone goes slowly through the distal crown, and it shouldn't be a problem. This is how it looks like in the PA projection of the patient. Usually the valve is much more longitudinal, it's much more straight, but this was a very special case. So the first SVC valve is in place, then we leave the catheter in the suprahepatic vein and we go for the SVC valve, IVC valve, sorry. You can leave the distal wire inside the atrium, or you can leave it inside the SVC. Just you can decide that in terms of how is the direction of the IVC inside the right atrium. You should try to look for a perfect alignation between the valve and the RA to IVC junction if possible. You can see here the images. You can see here on the right how we start deploying the valve. And once you're here, what you want to do is just to check that the amount of the valve inside the right atrium, it's not more than 10 millimeters. You can see here the transthoracic echo images. You can see it's quite easy to measure these dimensions inside the right atrium. And also you can put some color on just to check that there is no leaking and the valve is functioning properly. So if you're happy with the place or the height of the valve, you just go on unsheathing the valve. And this is how it looks like once you release it. This is the final angio. Obviously, the right atrium, which was huge, is still has got some regurgitation, but the valves are in place and functional properly. We could see in the hemodynamics that the right atrial pressure was ventricularized, but the V waves were avoided and the pressure above the valve or beneath the IVC valve were absolutely normal. The recovery of the patients, it's very quick. We usually leave the patients in a recovery room for a few hours and then transfer them to a standard ward after 4 hours or so. They usually doesn't need any ongoing ECG monitorization. We only perform the day afterwards, 24 hours after the procedure, chest X-ray and another transthoracic echo, and they can be discharged the next morning. Sometimes the patients have some shoulder pain through because of the dilatation of the IVC that you can treat with analgesics or maybe with gabapentin because it's a neuromediated pain. But the vast majority of the patients don't have any complications and can be discharged 24 hours after the procedure. Usually we wait about 1 week to 10 days to reduce diuretics, just as I said before, to allow the valve leaflets to work properly. And if we perform patients with mild to moderate reduced RV functions, they may need inotropes for a few hours, days. But as I said before, I don't recommend performing these procedures in patients with severely depressed cardiac function. We recommend chronic anticoagulation in all of these patients. And this is how it looks like the valve a week after the procedure. You can see that there's some improvement of the RV function. The valve is functioning properly on the left side with no regurgitation. Obviously, the TR stays in place. And just a few slides, 3 or 4 slides about the clinical data. There are a few papers published about the TriCPAL system. The main paper published is the Tricuspid study. It's a study including these kind of patients, patients not candidates for surgery with very bad functional class, and also tricuspid regurgitation over 3, grade over 3. We included 35 patients and we followed them. We had very, very few complications. Just 1 patient died in hospital. The technical success was 97%. This is the evolution of the quality of life questionnaires. This is the evolution of the functional classes. You can see there's a clear improvement in the majority of patients. 80% of the patients were in functional class 1 or 2 at 6 months timeline. And also this is the improvement in the walk test after 6 months. There's also the combination of the Tricus server with the Tricus registry, and I brought this slide just to show that the improvement is maintained 1 year after the procedure, and also that nearly 90% of the patients had improvement. There's also some improvement. We've got very scarce data on remodeling and volumes of the right chambers, but what we've seen is that there is some reduction of the RV volumes with some maintenance or even a bit enlargement of the right atrium. That's why globally the right chambers stays stable, but the right ventricle reduces its size. Also, this may explain the high pressure in the right atrium, why we haven't been able to see a reduction in the anti-proBNP levels. And that's really all the data we've got nowadays, but we've got an experience of above 200 cases, and I think the evolution clinically is really good. We're waiting for more data in a long-term follow-up. And this is what I wanted to show you. I'll be happy to reply any questions.